As that lovely introduction said, I'm a structural interventional cardiologist, which what that means is I do general cardiology as well as procedures. These procedures are both stents to the coronary arteries as well as procedures for your valve. These could include valve replacements, valve repairs, and we're going to kind of get into today some of the types of procedures we can do, as well as the symptoms that could alert you that you potentially, you or someone you know, maybe someone who it's worthwhile to get evaluated for valvular heart disease. So before we begin, and some of this will be pretty basic, but it'll be relatively quick, and then we'll get into some specific questions you guys have. But before we begin, what are the only two reasons to ever do anything in medicine, whether it's cardiology or any other time? There are two reasons, really. One is to make yourself feel better. That means you must be having symptoms. And this procedure or this medication, it's something that will have to help you feel better, be able to live your life a little bit better, be able to walk more, be able to breathe better, have less chest pain. The second reason is this intervention, is this medication going to help you live longer? So there's some things that you don't really feel. For example, high blood pressure. It's important to control high blood pressure because if you do, you can live longer and prevent heart disease. Even though when you take your blood pressure pill on a day-to-day basis, it doesn't really help you feel any better frequently. So as we go through this presentation, I want you to keep these two things in mind, because anytime your doctor suggests you do something, procedure or medication, you should think to yourself, is this going to make me feel better? Is this going to make me live longer? And if the answer to either of these things is no, then you really should question if you're gonna have to do that. When it comes to valvular heart disease, the reason why I chose to be a valvular heart disease specialist is because it's one of the few times in medicine where you can actually address both of these things simultaneously. People very frequently will feel better very shortly after the procedure, and many of these procedures have also been proven to help you live longer. So a lot of you may already know this, but what we'll do is quickly go through how your heart works, and we'll talk about some of these valves. So the heart has three systems: the electrical system, or the rhythm of the heart. This is kind of evaluated when you go to the doctor and get an EKG, or if they ask you to put a monitor on. The second system, which is what we'll discuss, is the pump function and the valves. And the third system is the coronary arteries, or the blood supply to the heart itself. On the right here of the screen, what you're seeing is an actual echocardiogram or an ultrasound of the heart. And it's the main way that we evaluate valvular heart disease. If you're able to see my little arrow, this here is one chamber of the heart, and this thing that's flapping back and forth is one of the valves. It's called the mitral valve, and it separates the two chambers on the left side, the left atrium and the left ventricle. This here, this very white narrow thing, you can see that it's another valve, and this is the valve where the heart squeezes and pumps blood to the rest of the body through this valve called the aortic valve. What you can kind of see here is this is very white, very thick. It's not nearly as thin as this one over here. So this is a patient that has narrowing of this aortic valve, or aortic stenosis, which is one of the main conditions that we're going to be discussing today. So how does the heart function? How does blood flow through the heart? So blood is collected from the body on the right side of the heart. It flows into this right here, the right atrium, and then it goes through a valve called the tricuspid valve into the ventricle. The atria are the chambers of the heart that really collect the blood. The ventricles are the chambers of the heart that push blood to where they need to go. So once the blood collects in the right atrium, right now it's been used by the body, so it doesn't have very much oxygen. It flows through this tricuspid valve, which looks like this, into the right ventricle. The right ventricle then squeezes with each heartbeat and pushes blood out through what's called the pulmonic valve or the pulmonary valve to the heart, to the lungs. In the lungs, the blood gets oxygenated. It then returns to the left side of the heart or the left atrium, which is right here. And the left atrium, from there, it flows to the left ventricle through a valve called the mitral valve. Once it is in the left ventricle, it'll squeeze. The heart will squeeze and push blood out to the rest of the body through what's called the aortic valve. These valves are very important because it allows blood to flow in the correct direction it's supposed to. So you can imagine if there are any issues with these valves, blood may go backwards, or they may not go forward well enough. And you could develop a series of or a whole host of symptoms that could potentially be resulted from this. So what can go wrong with your valves? We discussed these 4 different valves, and really there's 2 main things that can happen to them. One, they can start leaking. When a valve leaks, blood flows backwards from what it's supposed to. When one of those chambers contracts or squeezes, it's supposed to push blood forward to the next chamber. But if the valve that closes that off is leaky, when it squeezes, blood can go backwards which is in the opposite direction of what you'd want it to do. So what you're seeing on the left side of your screen is a mitral valve. If you remember, the mitral valve connects the left atrium to the left ventricle. And every time the left ventricle squeezes and pushes blood to the rest of the heart, this valve is supposed to close. So blood will only flow forward to the body and not backwards into the other chamber of the heart. On the normal side here, you see that with each beat, this valve closes very well. You see 2 leaflets, an anterior leaflet on the front and a posterior leaflet on the back. These leaflets are connected to the heart by these little cords. And with each beat, it opens and closes. Here it closes very nicely. Now, you can imagine if any part of this system, whether it's the valve itself, whether it's these cords, whether it's this muscle, whether it's this chamber getting too big, there are a number of different ways you could cause malapposition or the 2 leaflets to not come together appropriately. If this valve was damaged, if this cord was torn, if this ventricle got too big, these 2 leaflets would not come together nicely, just like they're not coming together nicely here. And what happens is when they don't come together, blood flows in the opposite direction. It leaks too much, and that can cause problems. Now, the second thing is narrowing of the valve. When the valve narrows too much, blood does not flow forward. If you can see over here, this is a normal aortic valve. The aortic valve has 3 leaflets, 1, 2, 3. And what happens is a normal valve will open up nice and wide. However, as you age, frequently due to calcification forming on the valve narrows and it doesn't open as well as it did before. So here you see here that this valve, due to some calcium that's kind of building up over here, it doesn't open as wide as this one. Now, when it doesn't open up as wide as this one, for this particular valve, when the heart's trying to push blood to the rest of the body, it is not able to push as much blood through this hole, which can result in symptoms. As well. And the other thing to keep in mind is when you have problems with your valves, the heart needs to work essentially overtime to try and compensate for that, whether it's trying to increase the heart rate or some of the chambers getting thicker or larger in order to compensate for this leaky valve. And that can also lead to both symptoms and long-term consequences. So what are the symptoms of valve disease? They can be many, they can be subtle, they can be severe. It's a very wide range and everyone's different. And the reason why the symptoms are so wide reaching is because, you know, as much as I love valvular heart disease and focus on it, it's not the only thing going on in your body. Very frequently, a lot of your different organ systems can manifest symptoms in similar ways. So for valvular disease, it can be related to shortness of breath, just as if you have some issue with your lung, you could have shortness of breath. But what frequently will happen is that a lot of people have multiple medical issues. They don't just have one. So someone who has a lung issue will, or like COPD or asthma, will say, oh, well, I'm short of breath because it's my COPD, it's my asthma. And it just continues getting worse. And what they don't realize is they have two problems. They do have COPD and asthma, but they also have some sort of valvular disease that's contributing to their shortness of breath. Chest pain, fatigue, fainting, these are all other things that can be caused by valvular heart disease. And if you can imagine that your heart having to work harder with a valve narrowing, for example, there may be some chest pain associated with that due to relatively complex phenomena, but it can be one of the presentations. Fatigue. You can imagine if your body is not pumping enough blood, if your heart is not pumping enough blood to the rest of your body, you could feel very tired. Decreased energy, trouble lying flat, because blood backs up into the lungs when you're lying down, because it's not moving forward the way it's supposed to if one of your valves is leaky, is another way. And then similarly, swelling in the legs can also be a symptom of valvular heart disease. So when you have these issues, there's several misconceptions that come with it. Frequently, people will say, you know what? Maybe I have some issue with my valve, but I'm too old for this. I do not want to undergo some sort of procedure. I've lived with this for a very long time. I don't want to do anything about it. And look, that is fair. It's everyone has a right to their own body and their own health decisions, and not everything is suited for everyone. But the idea that you're too old for this is not really an accurate one, because a lot of these valvular procedures were developed for people who are older, people who have multiple other medical issues. The reason for that is because those are the people who get valve disease. One of the most common ones, which we'll talk about, aortic stenosis or narrowing of the aortic valve, is something that mostly happens in older individuals. I've had a patient that was actually 101 years old, and we did a valve procedure on, and they did fine. So not everyone who's 101 should have a procedure, but it just gives you an idea that age is not the only thing that goes into making a decision on how to treat someone. Another thing that people say is that I'm fine, I don't have any symptoms. And you said at the very beginning, one of the only two reasons to do things is if you have symptoms. And if I don't have any symptoms, you can't make me feel any better. That's true. But what I would say to that is, one, a lot of times people don't realize that they are having symptoms. It gets to the last things listed here. Some people just feel that, look, I'm getting older, and this is what happens when you get older. You slow down a little bit. What they don't realize is that they are slowing down more than they need to. And this may be a result of some valve issue that can be fixed. The other thing that a lot of people do is they don't even realize that they're slowing down. They just slowly start limiting themselves. And before you know it, a lot of the things that you used to enjoy doing, you're no longer doing, and you don't even realize it. So the other thing is people think that these valve issues need to have open surgery. There have been a number of advances over the last 10 to 20 years that's no longer the case. Many of these procedures can be done with a small incision in the leg. And the most common one, which is TAVR, which we'll talk about, which is an entire aortic valve replacement, can be usually gets done in the span of about an hour and a half. It's 2 small incisions in the groin, and 75% of the patients at Valley go home the next day. So it's no longer a complete sternotomy, a complete open chest procedure. For some people, that is the right option. I'm not saying that there's no role for that, but in a lot of people, we can do this now more minimally invasive procedure. And then one of the other misconceptions I'll just mention is that a lot of people will say that, look, I'm just going to do medications. And medications certainly do play a role. They are needed in the treatment of valvular heart disease, but very frequently it's not enough. As you could imagine, valves are mechanical structures. The heart is very mechanical. And a problem with the valve is a mechanical problem. A mechanical problem will frequently require a mechanical solution. And that is either a valve replacement or a valve repair. So if you have a valve problem, what can you do? So there's 3 major options. Once again, medications are a mainstay of all these issues, so I didn't list them. So the first one, and the one that's traditionally used, is surgery. Surgery still definitely has a place, and some valve issues are best treated with surgery. Excuse me, but now very frequently a lot of valve issues can be treated with both minimally invasive valve replacement and minimally invasive valve repair. And what we're going to do over the next couple slides is we're going to talk about some of these valve issues, and I'm going to be showing you some animations about how these procedures actually get done. And I'll share some stories with you about some of the ones we've done. So while I talk, I'm going to let this play. But aortic, I borrowed this from the company that makes this valve. So aortic stenosis is the first one we'll talk about, and it's probably the valve disease that we treat the most. It's narrowing of the aortic valve. This typically happens to people as they get older. As they get older, calcium develops on the valve and it doesn't open up as much as it used to. And there's the issue becomes people tend to get symptoms from this. Aortic stenosis is a very important one to recognize, because once you start developing symptoms from a severely narrowed aortic valve, your lifespan is decreased dramatically. And if you fix the valve, your lifespan then goes back to someone who, or almost goes back to someone who never had aortic stenosis in the first place. Not completely, but for the most part, it's a dramatic improvement. So what are the symptoms of aortic stenosis? The 3 classic symptoms to look out for is 1, shortness of breath or trouble breathing, 2, chest pain, and 3, fainting. Now, that's not to say aortic stenosis doesn't present in other ways. Those are just the classic ones. Very frequently, people will get tired, more fatigued. They start limiting what they do. Those are all symptoms, as I described, of valvular heart disease in general, but also of aortic stenosis. So how does aortic stenosis get evaluated? The main way to evaluate aortic stenosis is with an echocardiogram or an ultrasound of the heart, similar to the one I showed you on one of the first slides. When they do that ultrasound, what they'll do is they'll evaluate the pressure gradient across the valve and it'll also measure the area of the valve. And if your narrowing classifies as severe, you would be someone who would potentially benefit from a valve replacement. Now, the evaluation for going through a valve replacement usually requires 2 to 3 steps. The first step would be visiting a structural heart clinic, like the one we have here at Valley, where you would meet an interventional cardiologist, such as myself, and you would meet a cardiac surgeon. We would discuss with you what your options were if you were a candidate for this TAVR procedure, the minimally invasive one, or if we thought surgery would be a better option. And then we would potentially make a decision. What you would also need to do is you would need to have a CAT scan of both the chest and the arteries that we would be putting the valve through. We would evaluate if you were a candidate based on your anatomy from that. Once you go through the evaluation, some people need an angiogram to look at the arteries of their heart to see if there are blockages. And then after that, we would potentially bring you in for the procedure. And this animation is showing the procedure. So let's go through it. Let's just go through it together. There are a couple different valves that are now commercially available. This one is the Sapien valve. It's the one we use very commonly. The other one is called the Medtronic core valve. And what the differences between the two are relatively small. They're both excellent valves. It's just different anatomies are better suited for different valves. So what you're seeing here is this is the aortic valve. Remember, this is the valve that when the heart squeezes, it pushes blood through this to the rest of the body. What you're seeing here is a lot of calcium buildup on this valve. It's not opening as wide as it should to allow proper blood flow. Here you're seeing the heart as well as the vessels in the body. What we would do is we would make a small incision in the groin, and we would put a sheath in there, which is about maybe a centimeter or so in diameter. And we would put a little wire up through your vessels. They're showing your kidneys over there. We put the wire through the up through the artery into the heart. We then bring a balloon. Some people need this balloon. Some people, we can just put the valve straight. We inflate the balloon so it pushes open the aortic valve. This right here is that aortic valve we were looking at before. We then remove the balloon and we then put the valve. Some people who are not candidates for the valve themselves can just get the balloon. The balloon will open up the valve a little bit. It's not nearly as effective as putting in a new valve, but it's better than having the aortic stenosis. So here what they're doing is they're bringing up the valve. This right here is the actual valve. The valve gets put on a balloon and it comes up around the aorta and it gets positioned where your old aortic valve used to be. We then inflate the balloon that we put it on, and it pushes the valve up to the sides. It pushes your native valve, the one you had in your body, up to the side, and the new valve now takes its place and sits there. And the new valve is now able to open up immediately. Now, a lot of people feel much better after getting this valve replaced. And like I said before, 75% of the people at Valley end up going home the next day. However, just like with any procedure, there are some risks associated with it. There's nothing, you see here now the valve is opening very well compared to how it did at the beginning. But like I was saying, it is a procedure, and just like any procedure, there are some risks associated with it. There's a small risk of bleeding. There's a small risk of infection. There's a small risk of abnormal heart rhythms. With these valve replacements, there's also a small risk of stroke. It's a lower risk than surgery, on the order of 1 to 2%. And there's a small risk of needing a pacemaker, because when you put the valve in, it can push on the electrical system of the heart. That's on the order of 5 to 10%. However, for people who have this disease, the risk benefits of doing this procedure, the benefits far outweigh the risks. And like I said, majority of people go home the next day. You would be seen in clinic a week later. And then periodically, we would do an ultrasound of your heart to check on the valves. So the natural question is, how long do these valves last? When you one of the concerns people had was how long would they last in relation to surgical valves? And since this is a relatively new technology, basically commercially available for like the last 10 to 15 years, we're learning as we go, but the data is very encouraging. In a recent trial that was published, when you look at 10-year comparisons, these valves hold up very well compared to surgical valves, which is very encouraging for the people that need them. Also, as we study this procedure more and more, we realize more and more people are eligible for it. Initially, we would do this procedure only in people who could not have surgery, who were too high risk for surgery. And when we studied that, these valves and this procedure worked very well. So then we said, what about people who are intermediate risk for surgery? And when we studied it and compared it to surgery, it turned out very well. So then we said, what about people who are low risk for surgery? And even those people, when compared to surgery, this procedure turned out very, very well in comparison. It was essentially equivalent to surgery. So that's why it's important if you have this condition, you are evaluated at a clinic where you can speak both to an interventional cardiologist and a surgeon, so you can hear the risk benefits of both procedures. So the next valve, the mitral valve, this is a condition that's a little bit rarer. It's associated with something called rheumatic heart disease, or people who've had rheumatic fever when they were younger. But it gives you an idea of a different way to treat these valves. So mitral stenosis means narrowing of the mitral valve. The mitral valve, as we discussed, connects the two chambers on the left side of the heart. And if there's a narrowing, blood does not flow from one to the other. The way to treat this is you could do a valve replacement, but if you didn't want to do open surgery, you could just balloon this valve. And frequently this valve, if you just balloon it, it turns out it works out quite well, and the results last a long time. What you're seeing in this animation is a procedure I've done where you use a transesophageal echo, which is an echocardiogram that goes into the mouth. You see it here, and on my screen, I'm able to see what the ultrasound is seeing, and I use both the X-ray, which is this image, and the ultrasound, which is coming from this, to guide my catheter across the mitral valve. Then what I do is I inflate a balloon. The balloon has two components, one on one side of the valve, the other one on the other side of the valve. And then inflate one, then inflate the other, and it opens up the valve. And like I said, generally people feel a whole lot better when they do this. A couple of years ago, I was actually involved in a program where they were screening young pregnant women in India for rheumatic heart disease, or for narrowing of the mitral valve. And me and one of the other physicians at Columbia, we went to India and actually did a couple of these procedures for the patients we found who had this condition. So the next one is something called mitral regurgitation. Regurgitation means leakiness of the valve. Now, if you have a leaky valve, blood flows backwards and doesn't flow. Filling the left. I'll talk a little bit more to that guy, but so what this procedure, let me rephrase. What happens with mitral regurgitation is the mitral valve is leaky, so blood doesn't flow forward like it's supposed to. It presents in the way we described before, with multiple different symptoms like fatigue, shortness of breath. Frequently, people will get very short of breath with mitral regurgitation. Traditionally, this was managed with medications or surgery. As you can see, this is kind of a theme with valvular heart disease. 20 years ago, none of this was available. This was all surgery that had to be used. Now, what we can potentially do is, if you have a leaky valve, we could clip it. The evaluation for whether you'd be a candidate for this is very similar to the evaluation for the TAVR that I described. What you would do is you would come to a structural heart clinic, and frequently what we'll do is we'll get an echocardiogram or an ultrasound of your heart. This time what we'll do is, to get a better look, we use something called TEE, or transesophageal echo, where instead of putting a probe on your chest and looking at the heart, they actually put a probe in your mouth. It's a lot easier procedure than it sounds. It doesn't sound comfortable, but it's a very common one, very safe. And we look at the heart from behind, and there we're able to see the leakiness of the valve. If you have severe leakiness and you have a suitable anatomy, you may be able to get a procedure like this MITRAL procedure. So the MITRAL procedure will frequently reduce the amount of leakiness. It'll lead to people feeling better, and in some studies has also been shown to allow people to live longer, especially some people with heart failure who have been on maximal medical therapy and are still having issues. For those people, it will also reduce the number of times they need to get hospitalized in the randomized studies they did. So let's start this over, and let's take a look at this procedure, how it gets done. This animation is showing the leakiness of the heart. This is the left atrium. This is the left ventricle. This is the mitral valve. As you can see, as the heart beats, this blue represents blood that's flowing backwards. Blood should flow from here into here, not backwards. But as the heart's squeezing, some of the blood is going backwards because these two valves are not coming together well enough. This is the MITRAL device. Through this series of knobs and levers, we're able to manipulate the little clip in order to perfectly position it. So the way we do the procedure is we get access to one of the veins in your leg, and we put up a catheter to your heart. We then cross across the heart from the right side to the left side, so we can get to the mitral valve. That's what you're seeing here. This is the catheter going across the left side to the from the right side to the left side. This right here is the mitral clip system being introduced. This thing over here is the actual clip. It's folded up on itself. What we do is we put it over the valve, and then we position it using those knobs and levers to try and get the clip to sit in the exact right spot, exactly where the leak is. We then continue to try and adjust it and look for where the leak is. So here in this particular animation, we see where the leak is, and then we kind of put the clip right there. So we lower it below the valve and then pull it up, so when the clip is open, the leaflets of the valve will sit on the clip. And then we close the clip to try and close off the leak. We then evaluate if everything is okay. If we don't like the way that it reduced the leak, we'll let the leaflets go, and then we'll try and re-grasp them. And once we feel like we have a good grasp, what we'll do is we'll then start to release the clip. And that's what they should be doing soon. There, they let go of the clip, and the clip sits holding the two leaflets together. This reduces the amount of regurgitation. And like I said, it hopefully leads to better decrease in symptoms, as well as in some patients an actual longer lifespan. So the other one that we'll talk about is the tricuspid valve. Similar to the mitral valve, which connects the left side of the heart, the chambers in the left side, the left atrium and the left ventricle, The tricuspid valve connects the right atrium and the right ventricle. Now, for the valves on the left side, they're a lot better studied, and the treatments are much more durable than the valves on the right side. Tricuspid regurgitation, or leakiness of this tricuspid valve, it is something that has traditionally been managed with water pills, as well as other medications. As we're learning more about it, it may also be a valve that could be amenable to transcatheter or these minimally invasive procedures. A lot of the treatments for the tricuspid valve are aimed at reducing symptoms. As of right now, the data for making you live longer is not as strong as the data for the other valves that I've described. And some of these are experimental devices. This is one such device that we use. It's called the Evoke valve. And what we do is we bring a catheter up across the tricuspid valve, and then we kind of open up this valve, and it has a series of anchors. And these anchors try and grasp on beneath the valve, and we have to adjust it such that it's in the perfect position. We then pull it back, and then once we feel comfortable that the anchors have grasped on, we can then inflate the valve and leave it. Like I said, a lot of these are investigational devices. The early data is encouraging. It seems to show that people have increased exercise tolerance. They report less shortness of breath. They get hospitalized less. So in certain cases, tricuspid regurgitation can be treated with this, though in many cases, medications is a great way to go. The last one that I'll talk about is aortic regurgitation. And like I was saying, that there are different valves available. One valve that can treat aortic regurgitation is something called a Yenna valve. And the way it is deployed is very similar to the first one I showed you, the one for aortic stenosis. Here, this sheath comes up and around the heart and gets positioned by the aortic valve. This is just showing how the catheter actually gets connected on our side. The valve gets brought around. And for the leakiness, it's a slightly different method of deploying it, because this valve is designed to be used in people who have leaky valves. People who have narrowed valve have a lot of calcium, so when you inflate the valve, it sticks there because the calcium anchors the valve. People who have a leaky aortic valve, it gets a little bit harder to anchor the valve. So this valve actually has these little clips here that you can help anchor, the valve itself. Here you're seeing the X-ray, them trying to get the valve in the exact right spot. And here they're opening up the valve to allow it to sit. So finally, what I'll say is that some people will say, well, I already have a valve from a surgery years ago, and that valve is no longer working. Do I have any options? Well, if you do have a prior valve, frequently what we can do is we can put another, if that valve is big enough, we can put a new valve inside of that old surgical valve. This is an example of us doing that right here. This is also something that's very, very common. The evaluation for something like this is the exact same as the evaluation for someone who had narrowing or leakiness of one of their other valves. Frequently, and on my side, sometimes it's even easier to put a valve inside of an old valve because you know exactly where to put it because there's an old valve right there. It's a lot easier to see. With someone who has a prior valve, sometimes it can get a little bit more complicated, but it's something that we do very, very frequently. So the conclusions. Valve disease is a rare field in medicine where treatment can allow you to both live longer and feel better if the problem is treated. Like I said before, valve disease is a mechanical problem that frequently needs a mechanical solution. These solutions in the past were open surgery. That is no longer the case. We can do these minimally invasive procedures much more easily, and they're designed for people who are older. They're designed for people who have multiple medical issues. And finally, I'll implore you not to ignore your symptoms. If you are feeling something, you should get evaluated. The initial evaluation for valve disease is just an echocardiogram. It's just an ultrasound of your heart. It's a relatively quick test. It's non-invasive and there's no side effects. And it's something that could potentially both improve your life and prolong your life. So I think it's very worthwhile to get it evaluated. So at this point, I'll open the floor up for any questions if anyone has any.
Hi, thanks, Dr. Rahim. There are several questions, so I'm just going to go through them one by one. So the first question is, having tracked my aortic stenosis for more than 10 years, it has slowly moved from mild to moderate and now is between moderate to severe. Should I consider TAVR before it moves to clear severe?
That's a really great question, and it's great that your cardiologist has been tracking your aortic stenosis very closely. Some of these classifications of mild, moderate, severe, they're very helpful in what we use to make decisions. However, it sometimes can get a little bit difficult because when you actually classify something as mild, moderate, or severe, you're looking at a couple different things. There are a couple different things you could look at. One, you could look at the velocity across the aortic valve. Two, you could look at the pressure difference across the aortic valve. Three, you can look at the area. Now, what can happen is that a lot of these measurements are very dependent on the type of image you get. And some of your classifications may be in the moderate range, some of your classifications may be in the severe range. And if you do an echo with someone who's specifically trying to look at the aortic valve, they may be able to get better images and hence notice more severity on it. So what I would say to you is that once you get to the moderate and severe range, you need to definitely watch it very closely and get your echocardiograms more frequently. And what I'd encourage is you also be very cognizant of your own body and notice if you're having any sort of symptoms. Once you get to this point, I would encourage that you kind of get evaluated by a valvular specialist and talk to your cardiologist if he feels that that's if you're at that point, because treating just like with any other procedure, any other surgery, treating it before you have any further issues or any other effects on your body is better than waiting for something to happen. So the short answer is it's very difficult to say without looking at the actual echocardiogram, but it is worthwhile to get evaluated by some sort of structural heart clinic.
Great, thank you. Next question. For mild mitral valve stenosis with the left ventricle ejection is 55 to 60%. Does that require medical intervention, and how fast can this deteriorate for someone who is fit in their late 50s?
So typically, and once again, it's very hard to know without looking at the actual echocardiogram and knowing a full history. Mm-hmm. But we typically only intervene on valvular disease that's usually severe. And whether you're a candidate for an intervention and what kind of intervention very much depends on what the mechanism of the mitral stenosis, of the narrowing of the heart valve. And also the progression of it also depends on the mechanism. So for example, rheumatic heart disease, which can cause mitral stenosis, will progress at a much different rate than calcific mitral disease, which is what happens in people who are older. And you can get an idea of the progression based on having serial echocardiograms. Typically, mild mitral stenosis is not something that's intervened on, but it's definitely something you need to keep track of. And once again, being aware of any symptoms that you might have.
Thank you. And what are the percentages for stenosis for moderate and for severe?
So around 20% of older individuals in the United States will have some sort of aortic valve disease. What happens is once you cross a valve area threshold of 1, that's considered severe. Aortic valve area less than 1 is considered severe aortic stenosis. A valve gradient greater than 40 is considered severe aortic stenosis. A peak velocity greater than 4 is considered severe aortic stenosis. But like I was saying, these numbers sometimes can be, they're not as rigid as they sound because the quality of your echocardiogram can vary, and the types of pictures they get can also vary. And then some of these can be discordant. Sometimes the valve area can look very small, but the velocity is not that high, which is why getting evaluated by a multidisciplinary team is important, because you need to kind of look at not only the echocardiogram, not just at the valve, but also at the whole patient and what's going on and how they're feeling.
Excellent. Next question. When you have valve disease, would both legs be swollen or would it just be one-sided?
The classic presentation is both legs, but like I was saying, that this is as much as I love to focus on valve disease, you need to keep an open mind because there's a lot of other things that could be going on. So you need a full evaluation for it. Classically, it's both legs, but sometimes it can be one. Every person is different, but usually what we look for is 2 legs.
Okay. And with a leaky aortic valve, is open heart surgery the only way to repair or replace it?
So, with the leaky aortic valve, there are other options, but it kind of depends. The classic way is surgery, and for most commercially available valves, aortic stenosis, the narrowing is what they're approved for. If you have severe aortic regurgitation and you meet the criteria for having an intervention done, surgery is still the main thing that we refer to. However, if you are a high risk surgical candidate, sometimes you are able to use these TAVR valves. It would be off-label, or you're able to enroll in a study. So I showed the animation of the Jena valve. The Jena valve is a transcatheter valve. It's not commercially available. It's actually only available as in a trial setting. But it's a potential alternative option to surgery for those who qualify for it. Once again, everyone's situation is a little bit different, and it's hard to do it without looking at the echocardiogram and meeting someone. But if that's something that you're potentially interested in, it's definitely something that if you make an appointment, we could talk about. The trial is not available at Valley. It's actually available at Columbia. But I only came to Valley in August, so I'm still very good friends with the person who's running the trial there. So if it's something that you could potentially benefit from, we could definitely talk about it.
Great. And then is valve replacement, is it just through the groin, or are there other ways of doing it?
So the easiest way and the way that is probably the safest is to do it through the groin. However, there are some people that have blockages in the arteries in their groin that preclude the use of the groin approach, preclude the use of the transfemoral approach, as we call it. So they are alternative access for TAVR that is a potential alternative to the transfemoral and an alternative to surgery. These alternative access routes, they're a tiny bit riskier, sometimes with a tiny bit higher stroke risk, but we also do them pretty frequently. In fact, the new cath lab director at Valley is a person who goes around the country that proctoring and teaching people how to do some of these alternative access ones, specifically actually using the artery in the arm to do the procedure. It's actually how we met. He came to Columbia to show us at Columbia how to do it. But the alternative access, sometimes people actually go through the carotid. Sometimes people go from a vein. Sometimes people go through the carotid. Sometimes people go through the arm. There are alternative access points, but the majority of TAVR procedures are done through the groin.
Okay, thank you. And then what are the prospects for minimally invasive repair versus replace for a person with moderate mitral valve regurgitation caused by broken chordae?
So that is a very difficult question to answer because a lot of it depends on how your transesophageal echo looks. So the mitral clip procedure, the minimally invasive repair, has been used for people with some ruptured chordae in very select cases. It's not what it was ideally studied for in trials, but sometimes it is an option. That would require a very specific evaluation of the actual echocardiogram to decide if you were a candidate for it.
Okay. And then what happens if the clip dislodges from the mitral valve?
Yeah, so that is a complication that can happen. It's very rare because we make sure that the valve, the clip is very steadily attached both ways in multiple different ways. If that happens, and if it is still attached to one of the leaflets, and if it's steady there, the clip will no longer be functioning. It won't be reducing your mitral regurgitation, but it is possible that it could stay there and not cause issues. But frequently, if the clip dislodges, it may require surgery to fix it. Rarely you can do a minimally invasive way of retrieving it, but usually if it's dislodged, it would require surgery. Also, if it dislodges, it's a very bad scenario. It's rare, but it's a bad scenario.
Okay. And what is the lifespan of a new valve?
It varies based on person. It varies based on the age with which it was placed, and varies based on your comorbid conditions. But what we're seeing is that you could probably and don't hold me to this, but you could probably say like around like 5 to 10 years is what a tissue valve will get you. Some people will be a little bit more. Some people will be a little bit less. But like I was saying, when we compare the surgical valves and the tissue valves, the surgical valves and the TAVR valves, so far the data is pretty good in terms of having similar lifespans. Mechanical valves, which are only surgically available, those will last a lot longer, but you do need blood thinners for those.
Okay, I think I just have 2 more questions. Once you have mild valve regurgitation, generally, will it get worse?
Like a lot of things, it depends on the mechanism of the valvular regurgitation. Like if it's related to heart failure, as you age, the heart failure may get worse and the ventricle may dilate, which may cause it to get worse. Some people can stay at mild for a very, very long time. It's all very, very variable, which kind of gets to the importance of having a follow-up echocardiogram, so you could get an idea of the progression. And that's really the best way to know, is just you follow it over several echoes and see. Some people it progresses very fast, some people it doesn't progress at all. It's just careful monitoring that's the best way to know.
Okay. And is Valley capable of performing mitral valve repair of broken chordae in the anterior leaf on a mitral valve?
So we do the mitral clips. Whether that specific one can be done, it really requires you to have a transesophageal echo and us to evaluate the transesophageal echo, because for that there are several different criteria we look at. The short answer, I know it's not the definitive answer you'd have liked, but the short answer is maybe.
Okay. I think questions are still coming in, and I apologize. So I'll just take two more, and then we're going to have to stop. For severe mitral valve stenosis as well as regurgitation, would the clip procedure be done along with the valve repair replacement, or would repair replacement resolve both issues?
It kind of depends on how bad the mitral stenosis is and the mitral regurgitation, because frequently when you have mixed disease like that, when you put a mitral clip in, it makes the valve area smaller because you're putting in a clip and squeezing it together. People who have pure mitral regurgitation, they usually have very large mitral valve areas, so it's not a big deal if you reduce the area a little bit. If you already have mitral stenosis and you put a clip in to narrow it even more, that could cause more harm than good. Excuse me. So for mixed valve disease, mitral stenosis and mitral regurgitation, typically we won't do the clip procedure. For those people who it's gone to the level of severe mitral stenosis, severe mitral regurgitation, which it is possible to have both, typically valve replacement is the way to go. The valve replacement that's currently available is for the mitral valve is surgical. There are some trials throughout the country that can do transcatheter mitral valves or minimally invasive mitral valve replacements, but those are still in a study phase. Sometimes if you have an old surgical valve and you have mixed disease, you could do a transcatheter valve. Similarly, if you have severe calcification and you have mixed disease, sometimes we can do a transcatheter valve as well. Like I was saying before, very frequently we need to actually see the echocardiogram in order to make a decision on that. And we also need the rest of the evaluation to really come to a conclusion.
Okay, thank you so much, Dr. Rahim. I'm still getting questions, but I know that you have patients to see, and it's 11 o'clock. So I just wanted to close up. If anybody has any other questions or whatever, you can always make an appointment with Dr. Rahim, and he has his phone number on the screen right now if you'd like to take that down. So